the second half of the prenatal infections are going to be those that cause congenital defects, usually when mom contracts them for the first time. These are going to be referred to as the torch infections, as the advanced organizer for reminding you which of these infections we're talking about. T stands for toxo, O stands for other and refers to syphilis, R is rubella, C is cytomegalovirus, and H is herpes simplex virus. Let's go through one at a time, recognizing that this is a great way to test you, the learner, by comparing 5 different diseases with one common advanced organizer, even though there's not a whole lot of overlap. Let's talk about toxo first. Toxo is caused by a parasite, that is T. gondii. It's a parasite that's going to be found, and you probably remember this from step 1, in cat feces. That's the primary risk that everybody recalls. Pregnant women who have not been exposed to toxoplasmosis prior should not be cleaning out cat litter. But they also come in the form of undercooked meat and cysts in the soil. So women in developing countries, as well as those in the first world, can contract toxo. The patient, that is mom, is going to experience a mono-like illness. Mono is Epstein-Barr. She's going to have fever, malaise, anterior cervical lymphadenopathy, hepatosplenomegaly, feel like crap for a long time. At that point, she's got a viral illness, and if she's pregnant, she knows baby's in trouble. And there's not much you can do for it because you don't really make the diagnosis of toxo until after the fact. When baby comes out, and these are the things that I want you to remember because they are buzzwords for toxocongenital syndrome, with brain calcifications, ventriculomegaly, big ventricles, or seizure disorder, you look back and say, hey, did mom have a mono-like illness during that pregnancy? And usually earlier on, the worse it is. You say, oh yeah, she did. Well, that means she probably had toxo. Nothing we can do about it now. But what you could have done was tested mom's antibody status. That is to say, if she is toxo antibody positive, that means she's already seen toxo and her body can defend against it, then she doesn't have to worry at all. Reassurance is the only thing she needs. If she were toxo antibody negative, she would need to be counseled on avoidance, get away from the things that would expose her to toxo. No cat feces, no walking around without any shoes, and make sure you cook your meat. Toxo antibodies are usually things that are done in the first trimester labs, but are not universal. Syphilis is the one you have to know the most about, simply because we know the most about it, and there's a lot of little details. Because syphilis is not syphilis. Syphilis is actually 4 different disorders, as we'll talk. The pathology here is Treponema pallidum. It's a spirochete. And it is a very unique infection and a very unique organism because it can present in so many ways. Regardless, it is a sexually transmitted infection. I want you to see this as 4 different diseases. Primary, secondary, latent, and tertiary. I'll explain EL and LL more. We have an entire video on genital ulcers and infectious disease where we review this topic in greater detail. Primary syphilis will present as the painless chancre. It is an ulcer on the genitals that doesn't hurt. As the spirochete gets into the system, it can reactivate, causing secondary syphilis. This is going to be targetoid lesions, and they will be on palms and soles. Very few things do palms and soles or rashes. Syphilis is one of them. Be careful, those lesions are contagious. Latent syphilis is you have a positive test, but no symptoms. And depending on when your exposure was, if you're sure or not, you're early or latent. That's not going to be so relevant for mom. Check out the infectious disease lesson for more on that. Tertiary syphilis is going to be any neurosymptoms. Classically, it's going to be the elder rake, the guy who used to sleep around, who can no longer feel his feet in space. But any neurologic symptom could be a sign of tertiary syphilis. The diagnosis is going to be made, same thing, primary, secondary, and tertiary. Primary syphilis, because the body has not had time to develop antibodies, you need to actually see the organism with a dark field microscope. Dark field microscopy is essentially not done anymore because no one knows what a dark field microscope looks like, but it will show up on your test. Secondary syphilis, because it's in your bloodstream and you have developed antibodies, you can get an RPR, which is the screening test, and confirm it with any of the tests that confirm syphilis. The one I want you to learn is the fluorotreponema antibodies. Tertiary syphilis is going to be diagnosed only by CSF studies, and you're looking for either the VDRL or the RPR. The VDRL is not as good as the RPR because it's positive in more things. Early latent and late latent syphilis are essentially diagnosed the same way as secondary syphilis, except you have no lesions, you're screening them asymptomatically. The treatment is very similar. Primary, secondary, and early latent syphilis all have the same treatment. What I want you to recognize here for a pregnant woman is the antibiotic is the same. You're going to use penicillin for everybody. All forms of syphilis disease are treated with penicillin. If you're penicillin allergic, you still get penicillin. Penicillin is the only right answer for the treatment of syphilis. If they're allergic, you simply do penicillin desensitization. For primary, secondary, and early latent syphilis, you need only an IM dose times 1. If you have late latent syphilis, it's still IM, but you need an IM injection every week for 3 weeks. More injections, spaced apart. If you have neurosyphilis, you're going to get IV penicillin every 4 hours for 7 to 10 days. The longer it's been around, the deeper it can penetrate. The deeper it can penetrate, the more penicillin you get. Recognizing that it's pretty easy to memorize the treatment because it's usually IM times 1, and the only thing you have to differentiate is late latent syphilis from tertiary syphilis to decide if you get 3 IM injections or 7 to 10 days every 4 hours IV. Remembering that even if she's penicillin allergic, she's going to get penicillin. Now, if baby gets exposed to syphilis in the first trimester, that's usually a dead baby. It ends up macerated, doesn't make it past the first trimester. Later on, usually in the later second and early third, is where you get the congenital deformities. The deformities, which can be remembered by the S's, that is snuffles, rhinorrhea, saber shins, and a saddle nose. The last S is sort of a fudge for Hutchinson's teeth. If mom gets syphilis during the first trimester, baby ends up dead. Third trimester, baby ends up ugly. That's syphilis as it relates to mom and baby. Let's now talk about rubella. Rubella, which is the German measles. In this condition, really only the primary viremia really impacts baby all that much. That is to say, if mom never got exposed and never was vaccinated and then contracted the virus while pregnant, that's going to cause baby some problems. You are going to see this in one of two ways. Either it is going to be the person who does have prenatal care who was not vaccinated. For whatever reason, she chose not to get vaccinated, or at least arrived in pregnant condition so that she could not receive the vaccine that she now knows she needs. That person needs to practice avoidance of the virus. The other person is going to be the person who has no prenatal care. which is the same thing as someone who's not vaccinated. Both of these patients didn't know they needed to get vaccinated, and now it's too late. The MMRV is a live attenuated virus, which mom needs to get 3 months prior to getting pregnant. If she gets it after getting pregnant, it's almost as if you're giving baby congenital rubella. In the condition here, either the person who chose not to be vaccinated or someone who never received prenatal care, the baby is going to end up with congenital rubella. And it's called blueberry muffin baby. Blueberry muffin because there are petechia and purpura all over a fat baby. And you're also looking at the C3 Cs, which is going to be cataracts, congenital heart defects, and deafness. Another advanced organizer doesn't work quite too well. If she contracts the virus in the first trimester, usually that leads to intrauterine growth restriction or straight up failed pregnancy, abortion, if contracted in the first trimester. You can't really diagnose rubella. Again, it's very much like toxo. If baby comes out as blueberry muffin and you say, oh yeah, hey, mom must have gotten that primary viremia while she was pregnant. Instead, what you're going to do is take this woman who's not vaccinated, who cannot get the vaccine, and then just practice avoidance. She needs to stay away from kids who are too young to have completed their MMR vaccine series, which places her at risk of exposure there. And she needs to stay away from sick people. What you'd want to do, though, is give her the MMRV vaccine. But this is live attenuated, so you cannot give it when she's pregnant. So it has to be before pregnancy begins, she gets preconception care and then finishes her vaccination series. The C in TURICH is really just to make the mnemonic work. CMV is not one you should commit to memory. It's much more important in transplant patients who have affected kidneys, not really so much in pregnancy. And so the things I want you to learn, because they come up on the test, not because you're really going to see it or check for CMV, is that it's a double-stranded DNA virus, and the patient is going to present with toxo that's not toxo. You're not going to do a whole lot for it, and you're not going to really diagnose it. It's just also in there, so it's probably going to be the wrong answer unless they give you some pathology slide. The idea is that CMV is a virus, Epstein-Barr is a virus, toxo is a parasite. They kind of all present the same with the hepatomegaly and the cervical lymphadenopathy, the vague viral illness. And so it's not really worth committing to memory CMV. Just know that, hey, it's out there to complete the torch infections. So when you see it, it's probably going to be a distractor. We'll finish with herpes. In herpes here, we're talking about herpes simplex virus. We're talking about the sexually transmitted infection. Now, we used to have it very nice and clean that HSV1 was different than HSV2 because HSV1 was on the mouth and HSV2 was on the genitals. Well, turns out that the mouth and genitals can go wherever they want, so it doesn't actually matter the location at all. HSV1 is HSV2, both are just as bad, and they cause the same disease in mom as they do in baby. Again, it's more the primary viremia that is the problem for baby. The primary viremia causes the congenital defects, whereas secondary reactivation puts baby at risk for getting infected. And the way herpes works is you get infected wherever you touch the lesion. The problem with herpes is that mom may be infectious even prior to the lesion being revealed. In this case, what you're looking for in mom is going to be a painful burning prodrome. And then an eruption of vesicles on an erythematous base. You do not need a diagnostic step. If you look at a lesion and say, yes, that's herpes, you're done. You can simply skip to treatment. But if you need to make a diagnosis, especially if there's an unroofed vesicles that have become confluent and have formed an ulcer, you can do a diagnostic step. It used to be that we use the zinc prep. And that's probably still going to be an answer on your test. And it's always wrong. What you're looking for is perinuclear molding, halos, the stuff on pathology. Now we've developed our science a little bit better. The right answer, if you're going to check, is going to be a PCR for the virus from a scraping of the ulcer. No viral cultures, no zinc preps, PCR is the right answer. The treatment for herpes is going to be either Val or acyclovir. You are going to treat mom with Val or acyclovir to reduce the lesions, whether it's primary or secondary viremia. Makes mom feel better. But because baby can be infected by herpes by passing through the birth canal that has active lesions, you may want to do a C-section. And generally it's recommended to do a C-section to get baby out. The only thing you need to be aware of is what happens if baby does get congenital defects, what to look out for, or how can you suggest that it was probably herpes that did it. Congenital herpes is defined by intrauterine growth restriction, preterm, delivery, and blindness. Just as a reminder, shingles, chickenpox, varicella, zoster, very similar to herpes simplex in the sense of it hiding in the dorsal ganglion, being a vesicle on an erythematous base, being bad for baby. Hopefully she's having preconception care and she's already getting immune to MMRV while she's getting immune to rubella. This back half, we covered those diseases that cause congenital defects. The torch infections. Toxo, stay away from cat feces, undercooked meat, and look for in the vignette, not in your patient, brain calcifications, ventriculomegaly, and seizures, and feed back towards she must have had toxo. Nothing to do about it. In syphilis, treat with penicillin. The answer is penicillin no matter what. In an OB question, it's going to be, she's penicillin allergic. What do you do? Penicillin. That's the answer. For rubella, you want mom vaccinated before she gets pregnant. But if she wasn't, you can't vaccinate because it will induce the primary viremia. Use avoidance. Pay attention for cataracts, congenital heart defects, and deafness. For CMV, know that it exists. HSV is going to be that painful burning prodrome and the vesicles on an erythematous base. Val or acyclovir for mom, C-section to remove the risk of infection as baby is delivered vaginally. That is prenatal infections.